Very good morning, sir. The presentation can be changed. It's Dr. Thirumalesh's presentation here. So I'll be talking to you about pharmacoeconomics. Presentation change. It is Dr.
एक प्रेजेंटेशन ऊपर वाले के ले लेना
डॉक्टर प्रदीप
डॉक्टर प्रदीप करके प्रदीप कुमार
चेंज करना है
Now we have the
this is
correct
okay.
presentation. Thank you. So I'll be talking to you about pharmacoeconomics of anti VEGF. I'm Colonel Pradeep from Army Hospital Ara. We have no financial interest in whatever we are going to say. The data has been obtained, thankfully, from the OEM sales reps, and the union government data is from .gov websites. I am thankful to the corporates for sharing the data of their sales. And there are three ways of looking at pharmacoeconomics. One, from the point of view of the doctor. Second, from the point of view of the patient and the government. So I'm going to try and amalgamate these three point of views. And what I want to share with you is help everyone understand pharmacoeconomics to show you how the government is planning to intervene in your clinical practice in future, how you can empower by presenting evidence to Health Technology Assessment Initiative of India, and how you are supposed to generate this kind of evidence. So first, to understand pharmacoeconomics, it is simply the science of telling us that when we compare the value of one pharmaceutical drug to another, which one is better. It basically dwells on the cost and effect of a pharmaceutical product. And the methods it uses is cost effectiveness analysis, where cost is measured in monetary units and the effects are measured wherever we find a lower ratio of cost to effectiveness, that particular intervention is preferred. So you have drug A, drug B, you measure the consequences and the costs, and you derive an incremental cost effectiveness ratio by the difference of the new molecule compared to the standard treatment and the benefits, and the one with a lower ratio is preferred. Next is cost utility analysis. So how is it different from effectiveness? Utility talks about the impact on the length of life and subjective levels of well-being. So quality associated life years is the best known utility measurement scale, and one QALY represents 1 year of perfect health. And when we talk about utility, this particular word utility we'll all have to remember in next 4 to 5 years to come. It talks about perfect health at ratio 1 and death as 0 and different levels of utility for various diseases. Next is cost benefit analysis, where we turn the benefits which are accrued from a certain intervention into monetary value. So the monetary value of vision reduction has to be assessed before arriving at a cost benefit analysis. And the costs which are going to be assessed are not only the direct costs but the indirect costs of treatment and the indirect costs of the impact that is going to have on the patient's life. And where the government comes in, it is the cost minimization analysis. This is where the government tries to figure out all the three methodologies and tell us, the doctors, that you're not supposed to use branded drugs but generic drugs. So what is the government doing as of date? Let's talk about direct benefits. Our union budget has increased from 84,000 crore to 89,000 crore over the past 2 years. But the budget allocation for NPCB comes under tertiary care program. And the tertiary care program has suffered because of the impact of COVID from 405 crores to 288 crores. When we talk about the blindness part, it is just 1/10 of this entire tertiary care program. Effectively, it gives you 3 crore rupees for retinal health if we talk about it. So where is the government reimbursing all the retinal health procedures that are going on today? By supporting the insurance agencies, that is CGHS, ECHS and Ayushman Bharat. I'll talk about it later. And giving institutional support to various central and state government hospitals. Retinal disorders, as has been agreed in all these previous talks, is the leading cause of visual impairment. And the problem occurs that the functional effect of loss of vision becomes extremely important in adulthood and older life when diabetic retinopathy and AMD become the key players in reducing vision. And the debilitating nature of vision loss includes 40%, you remember this figure, 40% in direct medical cost and close to about 60% divided equally between the direct non-medical costs which have been shown here and the indirect costs of productivity loss of the patient. Let me talk about one particular disease, the disease burden of AMD in India. If you look at this slide, we can calculate that there is a requirement of approximately 6 lakh patients requiring anti VEGF injections per year. And these are the sales figures which have been shared with us. When we talk about the innovator molecules, there were 1,14,364 sales in 2022. We talk about Razumab, they claim they have sold about 1,70,000 such units. And Ozurdex just came to about 33,600 units. Now, if we try to break down the unmet need, the requirement was of 18 lakh injections, while the approved drugs were only 3 lakh 18,000 sold. So where are the rest of the 15 lakh injections coming from? Either they are not being given, so the patients are going without treatment, or that gap is being fulfilled by bevacizumab. The cost of approved injection alone is 540 crore, and that too only for one disease, which is AMD. The government allocation cannot be beyond 540 crores by any means. So there is a huge difference in the budget allocation and the treatment requirement. Government is claiming that they are reducing the out-of-pocket health expenditure. They are producing such graphs where they are telling us that your out-of-health expenditure is now reducing from 64% to 45%. But please understand that any expenditure in a country, whether reimbursed or not, is borne by the country as such. And whenever you include health insurance in the entire gamut of things, it is an overhead expenditure. It actually reduces the direct benefit which is given to the patient from the government. What is this health technology analysis? So health technology analysis is an evidence-based decision making for healthcare benefit. It talks about two very important things in today's discussion of anti-VEGF. It talks about ethical issues, whether to use an approved drug and an unapproved drug also for giving safe and effective health. Now, the applications mainly require the decision making to tell us that what will be the reimbursement procedures, what will be the SOPs which doctors will have to follow, and the pricing and procurement of drug. This is where the corporates come in. The government will be empowered to talk to the corporates to reduce the price of certain drug if they want to practice in our country. Now, how we have postured ourselves. In 2014, World Health Assembly told us to put it in place. By 2018, the HTA in India was established. It is maximizing health by reducing out-of-pocket expenditure and, most importantly, reduce inequality. Both the rich and poor should get the same treatment. That is the objective. Now, this is the structure of HTA. Now we see that they are the ones who are going to be directing the policies. But who are going to give them the evidence? They have said resource hub, technical partner, and stakeholders. Now this very important part is stakeholders. When have we seen an eye specialist walking up to the government and telling them that please change your policies? This is where you and I have to come in and play our part. The current evidence of pharmacoeconomics has been amply explained in today's talk. We know that there is blindness. The blindness has not only direct and indirect costs. The health-related quality of life of blindness by AMD is almost comparable to be that of stroke. This is where and how we have to talk to the government, that if you're allocating budget for stroke treatment and coronary artery disease treatment, it has to be similar to the treatment of AMD also. This part has been amply covered, so I'll straight away jump to the direct cost 40%. Please remember this figure, and indirect cost 60%. So in real life, we see that pharmacoeconomic intervention can help healthcare professionals to make an informed and efficient decision. Within finite resources, we can distribute the benefits of these kind of anti-VEGF treatment to all. Now, the source of funding in India are not going to change. Between 2021 and 2025, they are going to remain equal. They can only be distributed into various subheads. So what and how we are going to deal with it? There where the crux of the equation comes. Let me talk about two molecules, aflibercept and bevacizumab. Here, in place of bevacizumab, I can replace it with ranibizumab, razumab, rani, any of the molecules which are 4-weekly acting. If I talk about aflibercept, the per dose 50,000 rupee approximate expenditure, 3,000 rupee expenditure in case of bevacizumab. But the follow-up with aflibercept is slightly lesser compared to what it is required with bevacizumab because the drug is more durable. So you see only 60,000 rupee expenditure in the indirect cost, where a 1,20,000 rupee expenditure in indirect cost with bevacizumab. Still, the drugs are not comparable. The aflibercept part will require 3 lakh rupee per year, while the bevacizumab arm will require 1,50,000. That is twice the expenditure. So you cannot explain to the government that please go ahead with a 3 lakh rupee drug compared to 1,50,000 rupee drug. How this can change? Just a small change. You move from aflibercept to brolucizumab. Here you can replace brolucizumab with faricimab or any other longer acting drug. And here you see that the number of visits of the patients are going to reduce. And now we are talking about comparable economic impact on both aspects. So these are just two examples how pharmacoeconomics can be used to advise the government. But let me come back to this particular example. It does not mean that aflibercept does not have a role. What the government is supposed to do is talk to the corporate and help reduce the cost of the drug across the country, which is achievable. And it can be achieved. Sorry, these were few cost calculators which I was supposed to cover. These are another method of pharmacoeconomics from patient's point of view, where a patient can also calculate the impact of the cost that is going to be consumed during his or her treatment. But these calculators are not the solution. The solution is to achieve cost reduction by using longer acting and more durable molecules. And we have to suggest to the government to reduce the pricing. The pricing is by reducing the tax. And how we are going to convince the government in doing so is by showing this kind of evidence. So I'll request that us, AIOS as a body, should now develop a health technology assessment bureau inside our organization, which has the authority to advise the government. Because if this task is left to certain government institution, I also belong to a government institution, it is not going to be enough because the voices are going to be lower. When all of us combine together and we have our unified voice going to the government and advising them that this is what you're supposed to do, they'll listen to us. Thank you so much.